Anemia. Aplastic. Its pathophysiology is it has this pancytopenia, plus there is this marrow hypocellularity. So marrow cells are decreased, and it's due to damage to pluripotent hematopoietic stem cells by different mechanisms. For example, intrinsic damage or extrinsic. Extrinsic means radiation, chemical, drugs, etc. And intrinsic damage means there is this defect in DNA repair, defect in telomere repair, defect in signal transcription. For example, defect in DNA repair is seen in congenital syndromes, for example, as we already discussed, Fanconi syndromes and dyskeratosis congenita. Others are defect in telomere this repair and defect in signal transcription. So also there is this in acute hepatitis or chronic hepatitis, patients can land up with this pancytopenia picture, especially with aplastic anemia. That is because of this immune mediated mechanisms playing a role here. So what happens to bone marrow? Bone marrow is replaced by fat, and stem cell pool is reduced to less than 1%. We discussed here acute or chronic hepatitis immune mediated. So what should one do? You see, note aplastic anemia. For instance, this aplastic anemia in young people after acute hepatitis is often immune mediated. So you have to treat with immunosuppression. So you have to give immunosuppressive therapy, and you don't have to treat with antivirals, because immunosuppressive will have good response. So how will a patient present? The clinical features, causes and other things we'll discuss it later, but we'll get a good exposure about how the patients present with this aplastic anemia. You see, onset is often abrupt or insidious, and most common symptom which we encounter, or the most earliest symptom, is bleeding. Patients present with bleeding because of decreased platelet count. So there is pancytopenia, that's why bleeding, fatigue, and this systemic signs, for example, fever, loss of weight, although they may indicate this neutropenia related feature. Fever, and this because fever will be because of this neutropenia related, for example, infection. There can be also a loss of weight, although that's not so common. So bleeding and fever plus minus infections due to low ANC count. So there can be history, for example, patients have received drugs, radiation. Patient can have viral infection, for example, hepatitis or Epstein-Barr virus or Parvo B19, or patients can have family history positive. So here clues will be Fanconi's or dyskeratosis congenita. Always remember these two, Fanconi's and dyskeratosis congenita. So examinations, what will you see? You will see petechia or ecchymosis due to decreased platelet count. You can see pallor, and although not so common, lymphadenopathy or splenomegaly. Note that this lymphadenopathy or splenomegaly is an important point. Lymphadenopathy and splenomegaly is not common. If it occurs, it challenges the diagnosis of aplastic anemia. So you have to find an alternative cause. So always remember the presence of lymphadenopathy or splenomegaly. It rules out aplastic anemia. So aplastic anemia is not there, and it can suggest alternative diagnosis. For example, patient can have leukemia, Patient can have LGL, patient can have lymphoma, patient can have infections like Kala-Azar. So leukemia, LGL, lymphomas and Kala-Azars. And there are two peaks in aplastic anemia. One is one is teen age, another is old age. So teen, for example, age of 20 around, and male female predisposition is same. So how will you evaluate this? You will, on examination, for instance, you run clinical and this lab test. You run lab tests. You will see on smear that there is macrostic anemia with leukopenia and thrombocytopenia. So macrostic anemia plus leukopenia and thrombocytopenia. So why this macrostic anemia? It's due to stress erythropoiesis and not due to vitamin B12 and folate deficiency. And we know that it is a pancytopenia with hypocellular, so heretic count will be low or inappropriately normal despite having anemia. So differential diagnosis also becomes immature myeloid forms because of increased MCV. So patient can have we will put MDS and leukemia as differential diagnosis here. Plus we know that nucleated RBCs will come in this. So myelofibrosis and myelophthisis is also a potential differential diagnosis here. You see, first let's correct the premise, and aplastic anemia usually doesn't cause doesn't cause this microstic anemia. So this doesn't happen in aplastic anemia. So they usually present with normostic or macrostic type of anemia. So why this is important? Aplastic anemia is, we know that it's bone marrow hypocellularity. It affects all three cell lines leading to pancytopenia. But the RBCs are usually normostic or mildly macrostic, but not microstic. So why macrostic or normostic in aplastic anemia? You see, there is reason being, one is reticulocytopenia. So low reticulocyte count means absence of smaller younger red cells. That's retics are, we know, because retics are usually smaller. Second is impaired DNA synthesis. In some cases mild macrocytosis due to ineffective erythropoiesis. Third is it can be associated B12 folate deficiency, especially in long-standing marrow stress or poor nutrition. So associated B12 or folate, that's especially in long-standing, not in early stages. Long-standing marrow stress or poor nutrition. So when would a patient with aplastic anemia show microstic anemia? Although this is very rare, but possible in certain scenarios like coexisting, for example, iron deficiency, for example, chronic blood loss, for example, menstruating female occult GL loss or nutritional deficiency, repeated blood samples or lab confusions. Sometimes they have these early phases before full cytopenia or misclassification. So always think microstic anemia means iron problem, macrostic anemia means DNA synthesis problem, and pancytopenia with hypocellular marrow, think aplastic anemia. So in bone marrow biopsy, what will you find in bone marrow biopsy in aplastic anemia? So what will you find? One is first we'll do aspirate, bone marrow aspirate. So you'll see it will be pale or dilute and RBCs will be present with scant cytoplasm. And biopsy will show this fat dominant fat, and hematopoietic cells will be reduced to less than 25%. And there will be absent or reduced. So absent or reduced megakaryocytes. And although this is not common, there can be dry tap, which is also seen in myelofibrosis or myelophysis. So always remember the diagnosis of aplastic anemia requires bone marrow biopsy, not just aspirate. Why is this? Because bone marrow aspirate may appear falsely normal if dilute or patchy. That's why we have to do this core biopsy along with aspirate in these cases. Note that I'll give you a side box. Always remember teardrop cells means fibrotic marrow. Teardrop cells means fibrotic marrow. And this teardrop cells plus nucleated RBCs and immature myeloid cells. So this is immature myeloid cells. So these three things, these findings are part of leukoerythroblastic blood picture, and they tell you that something abnormal is happening in the bone marrow, either infiltration, fibrosis, or massive stress. For instance, so this leukoerythroblastic, this triad, teardrop cells, nucleated RBCs, and immature. This is leukoerythroblastic picture. So this is seen in myelofibrosis, and for instance metastasis is myelophysis, and third is this severe infection or sepsis. So to summarize, patient, for instance teen or old age, be it male or female, presenting with pancytopenia. Most common symptom is bleeding from somewhere, and bone marrow showing hypocellular, fatty hypocellular marrow with absent spleen, nomegaly, and absent lymphadenopathy. So your mind should go towards aplastic anemia. And marrow cellularity less than 25% with less or equal to 30% residual hematopoietic cells confirms diagnosis when it's associated with cytopenia. So I'll explain this. So what is this bone marrow hypocellularity? Now cellularity means percentage of bone marrow space. This is the percentage of bone marrow space that's occupied by hematopoietic, that's blood forming cells, versus fat. So it is the percentage of space, bone marrow space occupied by hematopoietic cells versus fat. So normal cellularity is equal to 100 minus age plus minus 10%. For instance, for a 30-year male or female, it will be 70 plus minus 10. So it will be 60 to 80% bone marrow cells. So when we say what does less than 25% cellularity mean, it means the marrow is mostly replaced by fat, so very few. So bone marrow cells are present in less than 25% of this space. So means the marrow is mostly replaced by fat, so very few active blood forming cells are there. That's why in aplastic anemia we have fatty hypocellular marrow. So fat is more, cells are less than 25%, and there is marked decrease in all cell lines, in all 3 cell lineages, and there is no sign of malignancy, fibrosis, or infiltration there. So what is this less than, now what is this less than 35% residual hematopoietic cells. This means of the total marrow seen, of the total, if this is the total marrow, less than 35%. So less than 35% of it is composed of the real hematopoietic cells, be it WBCs, RBCs, platelets. The rest is fat or empty space. So of the total marrow seen, less than 35 of it is composed of this real hematopoietic cells. This confirms marrow failure, not just decreased production of one lineage. So this is the diagnosis of aplastic anemia. So why is this important? As per major criteria, for example, BACIGA, LUPO, or there are different names of this criteria, CAMETA or NIH guidelines. So what is this BACI, GALUPO, CAMETA or NIH guidelines? The diagnosis of aplastic anemia requires hypocellular marrow plus peripheral cell cytopenias, and there should be no infiltration or fibrosis or dysplasia. So no infiltration, no fibrosis, and no dysplasia. This is the diagnostic criteria. Decreased or hypocellular marrow, peripheral cytopenias, and no infiltration, fibrosis or dysplasia. IFD. I will do an FD. Infiltration, fibrosis or dysplasia. So hypocellular marrow means less than 25% cellularity, or less than 30 to 35% with few hematopoietic cells. Peripheral cytopenia means at least two of the following, that is ANC of less than 500, that's one criteria. Second is this platelets less than 20,000 per millimeter cube. Third is reticulocytes of less than 60,000 per millimeter cube. So ANC of less than 500, platelet of less than 20,000 per millimeter cube, and reticulocytes of less than 60,000. So by this, no infiltration, no fibrosis, no dysplasia, we rule out MDS, leukemia and metastasis. And so there will be no leukoerythroblastic picture, that is no teardrop cells, and there will be no nucleated RBCs, and there will be no immature myeloid cells, no teardrop, no nucleated RBC, no immature myeloid cells. So we can frame a question here. A 28-year female presents with fatigue, infections, so CBC showing anemia, HB of 6.2, WBC of 2000, and platelet of 12,000. Bone marrow biopsy showing cellularity around 15%, hematopoietic cells less than 25%, and no fibrosis and no blasts. So no fibrosis, no blasts. Diagnosis: severe aplastic anemia. So we will discuss this one thing, that is these are two related but distinct concepts. One is this bone marrow cellularity and residual hematopoietic cells. So bone marrow cellularity and residual hematopoietic cells. I'll give an analogy. So you see, imagine bone marrow has 100-seater auditorium. Cellularity means how many seats are filled there. So how many seats are filled versus how many cells are this empty or they contain fat. So this is filled versus empty or this. So if I say, for example, 20 out of the 100 seats are filled, that means cellularity is 20%. But we do not know what's filling those seats. So for instance, if only, so one scenario was this: 20 seats, 20 out of 100 seats are filled, that means cellularity is 20%. But if only 10 out of those 20 seats so if only 10 of those 20 seats have real students and rest are janitors, for example, or statues, so we will say hematopoietic cells is equal to 10% of the total space. So cellularity is how many seats are filled, and residual hematopoietic cells is how many of the filled seats are occupied by real students. By real students I mean RBC, WBC and platelet precursors. So you can diagnose, so final clinical takeaways, or you can diagnose aplastic anemia by either cellularity less than 25% or cellularity, for instance, if borderline, that is less than 30 to 35% and less than 30 to 35% hematopoietic tissue of total marrow space. But as long as there is no infiltration, there is no fibrosis, there is no dysplasia. So let's say question, for instance, a 32-year woman presents with progressive fatigue, easy bruising, frequent infections. She is not on any medication and has no significant past medical history. Investigation is showing HB of 7.2, for example, grams per deciliter. WBCs are also low, for example 1.1 multiplied by 10 raised power 9 per liter, and platelets are also low, for example 12,000. Reticulocyte count is low, LDH is normal. There is significance of LDH, we'll explain later. And peripheral smear, but this is important, there should be no blasts. First of all, there should be no dysplasia, because we have to rule out MDS. And there is this normostic normochromic anemia, not microstic anemia. So this aplastic anemia can present with microstic type of picture or normostic normochromic anemia, but never, although that's rare, but rarely it can present with microstic anemia. And we have done flow cytometry, FCM. There is no evidence of PNH clones. Bone marrow biopsy we did, that's showing cellularity of 28%. That's showing cellularity of 28%. But we know the diagnostic criteria was cellularity. Cellularity should be less than 25%. So this is not meeting the first criteria. Now, but cellularity less than 30 to 35, so it can fall here, but partially. So we'll explain this. So as per the question, there is cellularity of 28% plus hematopoietic cell content, so HCC, hematopoietic cell content, that is around 20% of the entire marrow space, and there is no evidence of dysplasia, fibrosis and malignant infiltration. So how do you diagnose this? So answer is aplastic anemia, because there is pancytopenia. Low retic count means marrow production failure. Bone marrow cellularity is borderline, that is 28%, so this is borderline. And bone marrow cellularity is borderline, but hematopoietic content, that falls in the second criteria. It's less than 35%. of total marrow space that satisfies diagnostic threshold for aplastic anemia, and there is no dysplasia or blast that rules out MDS and leukemia. No fibrosis means that rules out myelofibrosis, and normal MCV plus pancytopenia rules out iron deficiency. So this is aplastic anemia. Note that Parvo B19 classically causes pure red cell aplasia. We know that, but it can sometimes trigger aplastic anemia, especially in cases like this sickle cell disease, thalassemia, and immunocompromised patients. Now there is a concept of increased LDH and increased uric acid in pancytopenia. It is not seen everywhere. You will never see this in aplastic anemia, but you can see in leukemia, for example, acute leukemia, and you can see in lymphoma, for example, high-grade lymphoma, and you can see in MDS, you can see in megaloblastic anemia. So you see the mechanism is LDH means lactate dehydrogenase. So this is released from rapidly dividing or destroyed cells in conditions with high cell turnover. For example, leukemia, for example, acute leukemia, and megaloblastic anemia. There is excessive cell lysis or ineffective erythropoiesis. LDH spills into blood from dying or proliferator precursor cells. Also, increased uric acid. We know that it is a breakdown product of nucleic acid, that is purine metabolism. And when there is increased cell destruction, especially of nucleated cells, what happens? DNA or RNA breakdown. It leads to purine release, leading to increased uric acid. So that's why it is seen in leukemias, especially AMLs or ALL, and patient can have also this. Also in this setting, tumor lysis syndrome, high-grade lymphomas, and MDS when there is this ineffective erythropoiesis. But why not in aplastic anemia? You see, marrow cellularity is decreased. There is empty marrow. Cell production is severely low. There is no hyperplasia or turnover. That's why there is cell destruction is not happening. So no lysis occurring, and there is ineffective erythropoiesis. There is no attempt to make cells. LDH is thus normal or slightly low. Uric acid is also normal. So in aplastic anemia, the stem cells are destroyed or suppressed. So there is no proliferation, no effective hematopoiesis, and no lysis. Therefore, no excess LDH or uric acid. So if a patient, for example, a patient presents with pancytopenia. Labs show LDH of 890, uric acid 9.6, and macrocytosis. Peripheral smear reveals hypersegmented neutrophils. What is the most likely diagnosis? Pancytopenia, LDH is increased, uric acid is increased, there is macrocytosis, there is hypersegmented neutrophils. We know that this clinches the diagnosis of megaloblastic anemia. Now, what is the prognosis? You see, we say severe diseases when there is any 2 out of 3 present. One is corrected reticulocyte count, CRC, less than 1%, and absolute reticulocyte count is less than 60,000. Second is ANC of less than 500. Third is platelet count of less than 20,000. So ANC count of less than 500, platelet less than 20,000, and CRC less than 1, or absolute reticulocyte less than 60. So this is severe disease. When you 2 over 3 present, you will label the disease as severe disease. Other poor prognostic factors, one is this PNH clone. This indicates stem cell fragility. If patient have short telomeres. This is seen in inherited marrow failure syndromes, for example keratosis congenita. Also third is, so inherited syndromes, they have short telomeres, short DNAs, they make a poor prognosis. Third is somatic mutations, for example ASXL1, DNMT3A. These are linked with progression. Why these are poor prognostic factors? Because these are linked with progression to MDS or leukemia. ASXL1 and DNMT3A. Management is, you have to do hematopoietic stem cell transplantation, you have to do immunosuppression, also this Eltron, Bopag, androgens. There's a role of androgens and supportive care. Hematopoietic stem cell transplantation is the first choice. It is the first choice in young patient with fully matched siblings. So young patient, by that we mean less than 40 years, because it has got a long survival of 90% and mortality, although that can happen due to infection or chromosome graft versus host disease. We can also go for matched unrelated donor transplantation. It is the initial treatment in kids and salvage treatment in adults. But fully matched sibling donor is preferred in young patients, first choice, less than 40-year age. Immunosuppression therapy, we have this immunosuppression therapy. We use this anti-thymocyte globulin, and we have cyclosporin. Anti-thymocyte globulin and cyclosporin. So this is the treatment of choice in patients lacking a suitable marrow donor. So in patients where you will not prefer this hematopoietic stem cell transplantation, you go for this chemotherapy regime. Recovery is around 60 to 70%, and it has got a better prognosis in children in early robust. There will be this early robust hematological response. Early means less than 2-month response. And with anti-thymocyte globulin, there is a risk of serum sickness. And you also have to this, when you taper this cyclosporin, you have to monitor CBC closely, because this is where this relapse occurs. So what is the disease evolution while on ATG? Some patients of AAH, aplastic anemia, can develop PNH. 15% can develop MDS, and some can really develop leukemias. So aplastic anemia can go into PNH, 15% into MDS, rarely into leukemias. Adverse reactions, as I already mentioned, one is serum sickness, another is cyclosporin can cause, one is nephrotoxicity, and another is hypertension. So complications of this chemotherapies, one is relapse, another is malignancy. Now, so what is this IST versus hematopoietic stem cell transplantation in aplastic anemia? You see, in young patients with a suitable sibling donor with severe neutropenia, you will go for hematopoietic stem cell transplantation. But older patients with no suitable donor and less severe neutropenia, you will prefer for this anti-thymocyte globulin plus cyclosporin, ETG plus cyclosporin. So what is the response to treatment? You will see absolute reticulocyte count of less than 25,000 and absolute lymphocyte count of greater than 1000. You see this ARC of less than 25,000 and absolute lymphocyte count of greater than this 1000. So what is this ARC, absolute reticulocyte count? You see, it is the actual number of reticulocytes in circulation. Formula of ARC is reticulocyte percentage multiplied by RBC count divided by 100. Normal range is 50,000 to 100,000. Where these are 50,000 to 100,000 cells per microliter. So it reflects total marrow output regardless of degree of anemia. So this is what is the total marrow output, but it is regardless of degree of anemia. So anemia is not taken into account here. But what is this CRC? Corrected reticulocyte count. It is a reticulocyte percentage. So this, that's adjusted for degree of anemia. So why why is this to be adjusted? So what happens when patient is anemic? Reticulocyte, what happens that reticulocyte percentage appears falsely elevated. So in this there is false elevation of this reticulocyte count. So CRC is equal to retic percentage multiplied by patient's hematocrit divided by hematocrit that's normally seen. Normal hematocrit we make 45, then we calculate this CRC. So its use is to determine if the marrow is responding appropriately to anemia or not. Then RPI, reticulocyte production index. For more accuracy in severe anemia, the reticulocytes released are immature, that is the shift reticus, and need time correction. So RPI is CRC divided by maturation time in days, because we know maturation time increases as hematocrit drops. So ARC is decreased in aplastic anemia, there is marrow failure, and CRC is increased in hemolytic anemia or blood loss, and RPI, for example, less than 3 means good response, RPI less than 2 means inadequate marrow response. Now we know that as per NEJM 2017, this one drug, that is Bupag, this drug was added upfront in IST because it improved and increased response in adults and is used in refractory aplastic anemia. So this is refractory aplastic anemia, and it's also added to IST in adults. You see, unlike EPO, erythropoietin, HGF, or granulocyte colony stimulating factors, this TPO mimetics, that is this Eltromopag, they have shown robust tri-lineage response. They have shown tri-lineage response in aplastic anemia. How? Because it stimulates hematopoietic stem cells and it causes iron chelation. It's increase in regulatory T cells, leading to less immune attack. So it leads to increase in regulatory T cells. So it has three these mechanisms. So role is we use this drug as an add-on to ATG plus cyclosporin and leads to improvement in response rates. And it's also used in telomeropathies. So you can start with in older adults with no suitable donor and less severe neutropenia. You can also start Eltrombopag, this Eltrombopag plus antithymocyte globulin plus cyclosporin. This although a TPO mimetic, but it increases it tri-lineage response. So coming to androgens, role of androgens. So androgens are used in moderate aplastic anemia and also in telomeropathies. So mechanism of action is there is upgradation of telomerase gene activity. So role is in moderate aplastic anemia or telomere, and duration of treatment is you have to give 3 to 4 month trial. Then there is this role of supportive treatment. You have to give empirical broad spectrum antibiotics with or without antifungals in case for infection control, and you have to do source control and granulocyte transfusions in case of neutropenic refractory fever. Neutropenic refractory fever, you can go for this granulocyte transfusion. Also hand washes and PRBC transfusion if HB is less than 7 grams per deciliter, but you have to maintain around 9 in cardiopulmonary diseases, and you have to give SDP transfusion if platelet count is less than 10,000. That is the goal here. And but you have to avoid excessive transfusion in aplastic anemia because it leads to alloimmunization. So you have to avoid excessive blood transfusions, because new blood transfusion that you are giving, for example PRBC, that will contain RBC antigens that you don't have. Your immune system recognizes them as foreign and you make antibodies. That's called alloantibodies against those antigens. And who is at risk? Patients who are receiving repeated blood transfusions, especially thalassemia major or sickle cell disease or myelodysplastic syndromes or aplastic anemias or bone marrow failures. So what are the consequences? There is this problem with this is delayed hemolytic transfusion reaction. Patient already has alloantibodies and transfused RBCs with matching antigen are destroyed, and difficulty finding matched. Another issue is, so this is delayed hemolytic transfusion reactions. Another is difficulty finding matched blood. So the more antibodies the patient forms, the harder it becomes to find compatible blood donors, and thus the transfused cells will have shorter lifespan. Even if matched blood sometimes may get attacked if minor antigens mismatch exists. So transfusion failure will eventually happen, and so it will provide less benefit from transfusion. HB doesn't rise as expected. So that also creates sometimes risk in future pregnancies. For women, some RBC antibodies can cross the placenta and leading to hemolytic disease of fetus or newborn. So why do we avoid excessive transfusion? Because every transfusion is a potential antigen exposure, and each exposure increases the chance of alloimmunization. So how is this alloimmunization detected? How will you detect this? This is detected by doing antibody screening. That is, you do indirect Coombs test. And you do antibody identification panel. And this should often be a part of pre-transfusion testing. That is indirect Coombs test and antibody identification panel. So how do we reduce this? How do we prevent this alloimmunization? What are the various strategies? One is extended RBC phenotyping. You have to match donor RBC not just for ABO-RH antigen but also minor antigens like Cal, Duffy, KID, etc. So these antigens are to be matched. One is Cal, Duffy, KID. So thus extended RBC phenotyping. This is first strategy. Another is leukoreduction. So you have to do leukoreduction. This leukoreduction, what it does, it removes donor WBCs which carry HLA antigen. This creates, because that HLA antigen will lead to that has increased risk of HLA alloimmunization, and also so it reduces HLA alloimmunization. Third is use of so you have to limit transfusions. Fourth is you should use erythropoiesis stimulant agents in MDS because they have got a cellular marrow, or in CKD patients to reduce transfusion need. That's why you will often see CKD patients being put on erythropoietin, darbepoetin, because you have to reduce the risk of allo immunization. Because when the time will come and you have given multiple blood transfusion in CKD patients, time will come when you will transfuse the blood, and after a day or so, maybe less, there will be this delayed hemolytic reaction. Patient will present with hyperbilirubinemia, there will be again anemia, there will be maybe hemoglobinuria, so you might encounter such things. That's why erythropoietin is mandatory. 5 is you give immunosuppressive therapy. So in aplastic anemia or MDS, so to reduce the need of transfusion, you give immunosuppressive therapy. So let's frame a question here. A patient with prior transfusions who now shows unexpected positive antibody screen before transfusion, so you suspect allo immunization. In such case, what testing you have done? So this is indirect Coombs test you have done. This is the antibody panel you have done before this transfusion. That's why in such cases careful antibody identification and antigen negative matched units are required. So one was extended RBC phenotyping, leukoreduction, you have to limit transfusions, and you have to give erythropoietin stimulating agents. In extended RBC phenotyping, you detect KID, Duffy and Cal antigens also, apart from the usual that we do, that's ABO or rhesus antigens. Another step to reduce allo immunization is you give SDPs, not PRPs, the random platelet donors that you usually do. So leukoreduction or leukodepletion has a role here. Kindly subscribe this channel and like and share.